This lecture will describe vascular access about arteriovenous graft is called AVG. In the previous lecture, we described an overview of vascular access and arteriovenous fistula. In this lecture, we will describe arteriovenous graft. When the autologous vein is devastated by shunt obstruction or when it is difficult to create an arteriovenous fistula, an arteriovenous graft is implanted to bypass the artery and create an endovascular shunt. The area to be implanted is the upper limb or thigh. Types include expanded polytetrafluoroethylene, polyurethane, and polyolefin elastomer polyester. Implantation configurations include straight, curved, and looped. Grafts cannot be punctured for 2 to 3 weeks after insertion until they adhere to the surrounding tissue, but in the case of polyurethane and polyolefin elastomer polyester, puncture is possible from the next day. As grafts are artificial, they are susceptible to infection and prone to stenosis at the anastomosis with the vein. Compared to other VAS, it may be occluded more suddenly. Daily monitoring of static venous pressure and other parameters is necessary. There is a cardiac load. AVGs have different waiting periods before they can be used due to their material and structural characteristics. The characteristics of the inserted AVGs should be understood and used. The waiting period for EPTFE is 2–3 weeks postoperatively. But PU and PEP have characteristics that allow them to be used early postoperatively. It is necessary to understand the advantages and disadvantages of each AVGs. AVGs are more vulnerable to infection than AVFs. Disinfection should be extensive and appropriate. As with AVF, avoid repeated punctures at the same site and perform punctures as widely and evenly as possible. It is recommended that AVG be punctured at a more obtuse angle than AVF. If the puncture site is pressed too hard during hemostasis, it is likely to cause a blockage, so the bleeding should be stopped just enough to feel the thrill. The next lecture will be on catheters.